So thank you very much. And I would have winged it anyway. But I feel really honored, and I thank you, Joan, for inviting me, because I hear so often, what do you do as a care manager? So this really gives the opportunity to really explain what we do every day. So during the PowerPoint, we're going to go through, make sure you understand the definitions of what care management is, really explain what the inpatient care manager does. And there is actually a difference between care manager and case manager, so it's really understanding what those differences are. Understand the services of what a care manager can arrange for all patients across the continuum, and also to understand how a care manager will assist in meeting the needs of the patient and family to prepare for discharge. Understand how to be prepared for trips to the emergency room, and also it's always important to have the advanced care planning and to really understand why it's needed. So let's start by looking at the definition of exactly what is a care manager. Care manager is actually defined as applying systems, science, incentives, and information to improve medical practice and assist consumers or patients to support their systems to really be engaged in a collaborative process. So it's not just the care manager telling you what to do about your discharge plan. It really involves everybody. Most care managers are social workers and registered nurses. We do have some with psychology degrees. Care management is designed to manage medical, social, and the mental health conditions more effectively. And really the goal of the care management is to achieve an optimal level of wellness to improve coordination of care while providing cost-effective, where we're not duplicating services, because I can't tell you how many times patients will go to the hospitals and the doctors and they'll have multiple tests done, which is really not fair to the patient, and also it's not cost effective for our healthcare system. So the question is care management or case management. I kind of already answered that. Is there a difference? Most people think there isn't a difference, but there is a slight difference. Case management is what we used to always do in the past, and it refers to limited and episodic services where the focus in improving patient health and reducing financial costs. So that's more like when you focus more completely on discharge planning. That's all you did. And that's what we used to be called as discharge planners. And we did nothing else. We didn't think of coordination of care, any diseases. We just wanted to focus on what you needed to get out of the hospital. It's now care management. So that is a more holistic approach, and it's very extensive approach, which looks at the entire picture. What's going on with that patient, the patient system, functioning to improve outcomes, especially in our high-risk population. So our CHF, COPD, patients that have multiple readmissions, going to the emergency room frequently, high emergency room utilizations. This is the population we really focus on to give the best care. And which one are we doing in Virginia? It definitely is care management.
Excellent.
So the biggest question is, what does an inpatient care management do? So the responsibilities of care management is we really come up with a care plan to develop transition management and advocate for the patient. And one thing we're really pushing is advanced care planning. And that's not just for the elderly. That is, if you are 18 and above, you really need an advanced care plan. And we focus and drive that. And of course, if you have complex medical conditions, we push that even more. And also health promotion, because we want to teach you to be healthy, even though, yes, we are a business and we want you to come to the hospital. In the long run, we really prefer you to stay at home and get the most care you can at home. The goal of care management is to navigate the patient and their families, as well the care team, through the continuum of healthcare settings. And this also extends to the outpatient settings, which is really great with Bonds of Core because we have the nurse navigators, which they just recently changed their names. And so they're also the care managers on the ambulatory care, where we're able to help coordinate care with those. It is a little bit harder if they have a non-Bonds of Core provider because there's not a nurse to coordinate that care, but we do get in contact with the providers to help with that coordination, especially our high-risk patients with complex conditions. The care manager will also fully explain the discharge options for you, and that really involves patients and their families. It's not us telling you what to do. You have the choice. You can make the decisions of where you want to go and what are the best options to suit you and your family. A lot of people think that we're just sitting behind the desk and not doing anything. We do a lot of desk work, but we are very busy working behind the scenes to coordinate your care, following your hospital discharge, and transition you out of the hospital, just so everyone has a really safe discharge. That is what's most important. And often it's families, they want something, but we know it's unsafe. So it's when we have to come together and really talk about what's going on to understand what is safe and what's not safe. Ultimately, the patient still has the decision to decide whatever they make. Everyone has a right to make bad decisions. So care managers, that we are very busy, but one thing is we are never too busy to answer your questions. We will always include you in your discharge plans, and it's always important to keep everyone in the loop so you understand what's going on completely with your care at all times. So healthcare services and settings. The range of healthcare services and settings that we deliver are varied as patients who utilize them. A key component of the role of care manager is to educate the patient about all options they have and assist them to finding the correct option for them to go across the continuum of care. Every patient who has CHF will not have the same discharge plan. It is all individualized to meet the patient and family need of care. So if anyone doesn't know what transition of care is, that is actually the discharge options, moving them from one area to the other. So one of the primary functions of a care manager is to educate patients and services that are available along with different settings, coordinate those post-acute services to meet the patient needs. And so now we're going to look at what the variety of these options are. And as you can see, there's several, but it used to be in the past that we really pushed to send many people to rehabs or skilled nursing facility. But evidence-based practice recently has shown that the best place for patients to go is to be discharged home with services in the home. Patients do a lot better when they go home. That is not always feasible. Of course, we have to do what's the safest. But the primary goal is to get them home with any kind of services. We order some discharge home with durable medical equipment, which I will go into further what those are. We also schedule the primary care, PCP, or any specialist appointment. These are for our chronic condition patients. If you're coming in your 20s and you have just, the flu or something, we don't really schedule those because they're quite capable. It's our patients that are high risk and multiple comorbidities that we really focus on. We also work with dispatch health, outpatient therapy, home health, assisted living. We schedule dialysis for the home, and sometimes we also help arrange the dialysis when they go into the skilled nursing facilities. We have skilled nursing facilities, acute rehabilitation, long-term care, and a long-term acute care. And then also we arrange hospice with either home or the inpatient setting. So they'll either go GIP in the hospital or we could send them to the hospice house. So we're going to break these down all individually. So the primary care or specialists, we have a great outreach center that we work with together. They're called case management specialists, and they help us with arranging our post-discharge follow-up appointments before you're actually discharged. And so these appointments are scheduled within the 3 to 7 days after discharge. It really is so important for families to keep this appointment, because that really drives your care once you're discharged. And it also depends on the diagnosis, whether it's 3 days or 7 days. The outreach center will schedule the appointment. Even if they're receiving outpatient services such as home health, we still make sure they get into their primary care or specialists if they have CHF or cardiac issues, depending on what appointment they need to go to. I'm sorry. And what's really nice, if we cannot get the patients into their appointment in a scheduled and timely manner, or we can't get their home health within like a 48-hour time frame, we have this awesome service of Dispatch Health, and I saw Mary Catherine's on, to complete a post-discharge appointment. So we have also partnered with them to help us to make sure these patients really get their follow-up care after discharge. So to answer, why is your appointment so important? So follow up with your provider, medications, changes of doses and issues. That is the #1 reasons why patients get readmitted after discharge, is so many doctors are scheduling different medications and then they get confused and they're taking the wrong medications. So that is the highest rate of readmission because of medication errors. If there's any questions or concerns, they have an opportunity to follow up. And then also, it's improvement in being made to make sure there's no additional care needed. Sometimes they'll follow up with their primary care and realize, okay, they need an additional specialist. So that's the opportunity. And then CMS, which is the Center for Medicare and Medicaid Services, it's approximately 20% of patients that are readmitted within 30 days. Which is a large amount. And so that is just why this follow-up appointment is so important. And I often hear from patients, I'm tired when I'm discharged and I just wanted to go. So it's really fully educating them on why it's so important. I talked about durable medical, or DME, and this is where it used to be the case manager ordering all this. So we still do part of discharge planning. We order the wheelchairs, walkers, bedside commodes, canes, hospital beds, nebulizers, oxygen, Trilogy, CPAP, and life vests. So there's multiple things that we can order that, but we still have to follow in the CMS guidelines to make sure that, 1, your insurance approves it, and 2, that you're ready to get these equipment. If not, we work with you and the companies to see how you can pay for that. The next one is outpatient therapy services. So this is a variety of things that we offer outpatient, such as physical therapy, occupational therapy, speech therapy. These are geared to the preservation or enhancement or restoration of movement, really getting your physical function back. Sometimes when you come in the hospital, you get a little weak and you don't need home health quite yet. So it helps to get these outpatient therapies. And you could even do such as massage or electrotherapy. Also, if they need any assistive devices or patient education and training, it helps to have some outpatient therapy. This is really for the patients that don't qualify for home health. So as we know that for home health, you have to be homebound to get that. So if they're able to drive, we'll be doing outpatient therapy services. Services are also provided in therapy centers located in the community. And we can assess those services, mostly occur through a prescription from the patient's provider, either the primary care or the specialist. And all these services are covered under your Medicare Part B And there's a 20% copay that applies for these services. Home health is the next one. So obviously if you're homebound, we are going to do some home health, and we work for with multiple home health companies. Obviously it's patient choice, and we really recommend patient choice, you know, let them have, and then if they don't have any patient choices, per CMS guidelines, we do the star ratings and give them and let them make their own choice. But home health provides intermittent skilled services to patients considered to be homebound. And homebound actually is defined as takes considerable taxing effort and requirement of assistive devices to leave home. So that doesn't mean if you're going to your doctor appointment, it doesn't make you homebound. You can still be homebound, even if you can get to your doctors. Some of the services provided by home health is skilled nursing, physical therapy, speech therapy, occupational therapy, medical social work, home health aides, and even telehealth. So it's almost the same thing as outpatient, but it's going into your home. And to get home health, you must be under the care of a provider. A provider has to write an order for home health. And Medicare Part A and or Part B pays for home health. So it comes into what home health doesn't cover. What Medicare does not pay for as personal aids, meals delivered to your home, housekeeping, or 24-hour-a-day care. If around the clock is needed, then it might be considered that home health might not be really what you should be doing. So we need to be thinking maybe you should go to a skilled nursing facility for a little while and get a little bit of rehab. Or if you have the money, you can pay out of pocket for these, and we work with many excellent services that can help arrange these individual services. So skilled nursing facility, this scares a lot of people just by this term. They think they're going into long-term care when you say skilled nursing facility, and it's not. Everyone thinks I'm going to a nursing home. So we really shouldn't use those terms interchangeable. It's the term skilled nursing that really indicates they need services, such as physical therapy or wound care. Patients have to be able to participate in those services. They also include occupational therapy, speech therapy, and it's mandatory for Medicare to pay for the patient's placement in these facilities. If the patient refuses to pay or participate, sorry about that, then payment for placement will not continue. So if a patient gets to a skilled nursing facility and all of a sudden they say, I just don't want to do this care, or I don't want to go physical therapy that day, they'll let it go like 1 or 2 times, but if it continues, they're not helping themselves get better, and they can no longer stay in a skilled nursing facility. Nor would I be able to get a patient into a skilled nursing facility if you're not working with physical therapy in the hospital. So Medicare Part A pays for the skilled nursing facility for rehab, but there are many conditions that must be met. During COVID, it was kind of nice because these conditions weren't required, but they are now coming back. That was a brief time for only a couple months, so we're back to where we used to be. You must have a 3-night stay from inpatient to be eligible for a skilled nursing facility. This means the patient must be inpatient for 3 nights, not observation. And it counts from the time you get your inpatient order, and then 3 nights from that. And then after that, we can get you into an inpatient setting. Medicare will pay for day 1 to 20 at 100%, and then days 21 to 100 at 80%. So the patient is responsible for 20%, or approximately $165 per day. And this is a 20% copay is covered if the patient has a secondary insurance. Any days over 100 are not covered by Medicare. Now, I don't expect everyone to know that by heart. That's something we work with you whenever we get patients trying to go to SNF. We see how many SNF days you've used, and we're able to help navigate that and then come up with the next plan of care. In order for a new benefit period, meaning access up to another 100 days of SNF service, you must have a break of 60 days outside the hospital, and SNF setting would be required. So basically, to start over your days, you have to be out 60 days before you can get any additional. Long-term care, this is what we count as a typical nursing home. This means placement that is not necessarily medical in nature, but it consists of structure and support to provide help with any activities of daily livings that patients can't perform or have support to perform themselves. It's also called custodial care. And pretty much when you get to long-term care, you are there to the end of your life. And you also can do hospice and long-term care. So that's really nice also. I get this question a lot. Does Medicare actually pay for long-term care? And unfortunately, Medicare does not. So what's really going to help you is patients that have long-term care insurance will cover, and an additional policy can access if when long-term care is needed. Not many people think about that, but it's a really great idea to work with your parents or yourself to have an extra policy to help cover this. Other than that, patients will have to use their savings and resource to, one, either pay for it out of pocket, or you have to sell your assets, including your home, and that's what they call a spend down, to get Medicaid. And funeral costs does count as a spend down. That's the best way to quickly drop $10,000 right away towards your spend down. Acute rehab facility. This is some rehab that assists patients experiencing a loss of function from injury or illness to become independent as possible in their ADLs and return safely home to the community. It is similar to SNF. Medicare Part A covers acute rehab. Commercial insurance also covers it. If you have commercial, an authorization is needed. The average length of stay in acute rehab is shorter than SNF. It's about 7 to 10 days, where skilled nursing facilities approximately 20 to 23 days. Two skilled rehab services are physical and occupational and speech therapy. This is more intense therapy, so this is how we determine if you go to acute rehab versus a SNF. Acute rehab, you have 3 hours of daily therapy. So if we think you cannot tolerate 3 hours of daily therapy, then skilled nursing facility is the better choice for you. And then there is reasonable expectation that you must participate in the services to improve function. And then you also have to have a clear discharge plan after that to acute facility. And that's arranging home health of your choice. My next one is, if you have to come to the emergency room, you really need to be prepared, and nobody thinks about that. They're like, why do I have to be prepared to come to the emergency room? But it is so important for certain things to bring with you to the emergency room. A list of current medications really helps, because many people see multiple providers, and some of them aren't bonds of course, so we might not have that medication on your list, and you could have duplicate medications. So it's important to bring a current list of medications, and that includes your over-the-counter, any topical or any herbs, a list of your allergies, a list of your medical care team, and this includes all your primary care doctors, your specialists, physical therapy, and also an advanced care plan or advanced medical directive And also your family and friends for support, because we give a lot of information when you come to the hospital. And I know myself, it's even hard for me to retain. So it's so important to have someone with you to retain this. Now, I know during COVID that wasn't possible, but in normal times, it's so, so important to have someone with you to help you understand. And advanced care plan, I hear so many times, I have it. Well, it doesn't help us if you have it, if we don't have it on file, because we cannot follow it if something happens to you and you're no longer able to make your decisions. And I'm going to go that a little bit further here. So what is an advanced medical directive? It's also called an advanced care plan. And this is a legal document that empowers an adult with decision-making capacity to communicate future healthcare decisions in the event that he or she becomes unable to make medical decisions. This is what I said earlier. Anybody over 18 should have an advanced medical directive. I have one. So I encourage my children to have one. Advanced medical records do not have to be completed by an attorney. That is the old way. You used to always have to go to the attorney office, pay some money. You no longer have to do this. You can have this completed, one in the hospital or two by your primary care doctor. It requires an agent. So if you ask what is an agent is really the person you appoint to be your decision care maker. It does not have to be someone in your family. It could be your neighbor, your best friend. If you want your neighbor back, this is a reason to have it on file, because if something happens to you, it will go to your next of kin. And if that's not who you wanted, we're not following your wishes, but that's all the reason we have to have these advanced medical directives on files. And a completion of advanced medical directive requires the patient to have capacity. You have to be able to understand what you're saying, what your wishes are, and who you want to appoint. And once again, it's so, I can't reiterate this even more. It is so important to bring that copy advanced medical directives to the hospital so we know your wishes. Even if we have on file, bring it in every time you come in. I always say, put a file life on your refrigerator, which has your advanced medical directives, your DDNRs, all your doctors. So if you call an ambulance, have them grab that file life and all the files with you when you come to the hospital. So that one thing I said, capacity, what does capacity mean? And it really means that the patient is capable of making an informed decision. It means that you can understand the nature, the extent of probable consequences of a proposed healthcare decision. You should be able to make a rational evaluation of the risks and benefits of a proposed healthcare decision compared to the risk and benefits of an alternative decision. And then you have to communicate back that you understand these decisions. To be determined incapacitated, it really requires documentation of 2 providers before an authority of an appointed agent becomes operative. So there is a lot. If you have an advanced care plan, it goes in effect when you're no longer capable of making decisions. So if you don't have a decision maker, and this is why I said if you do have someone other than family, it's so important to have that, because if you don't, we go by the Virginia hierarchy of surrogate decision maker. And so first, if it's guardian for the patient. So whoever is the guardian, if you don't have a guardian, it's going to be the spouse. The only time it's not if there's a divorce that's been filed and the divorce is not final. The next it goes to the adult child. It can be either biological or adopted. It cannot be stepchildren. It has to be your biological or adopted child. If you have a parent, it's your parent, and then also adult sibling. Once again, it's biological or adopted. It cannot be any step children. And then next for that, if we don't find anybody, we start looking for other relatives in a descending order for like cousins, uncles, aunts, and unfortunately, we have had to do some searches and find relatives out there. And it takes some time. You can be really sick before we find someone who can make decisions for you. This one at screen is so important because there is a difference between advanced medical directives, a do not resuscitate, and a durable do not resuscitate. And I like this because it really explains the difference. So advanced medical directive is really written by the patient. You're capable of making decisions. You're saying what you want. And it's held until suspension until you're no longer incapable of making decisions or you're actually terminal. It's signed, dated, witnessed, and it's valid. It never expires. And what I like is most states will honor it from state to state as long as it complies with state laws and being executed. I have the question so many times, can I change my advanced medical directives? Yes, you can. You can change these anytime you want. My recommendation is when you do that, get all your old copies and dispose them and give everybody new copies. Please do not put your advanced medical directives in lock boxes. Make sure whoever's making your decisions for you has a copy, you have a copy, your doctor has a copy, the hospital has a copy. The more copies you have out there, the better. A DNR is actually a written order by the doctor. It could be a nurse practitioner or physical PA or an MD. It becomes effective when signed by the provider. The order is effective only in the facility which is written and through the first transport. So what that means is, say you're in St. Francis and you're going to a skilled nursing facility, it covers St. Francis and it covers your ambulance ride to that facility. Once you get to that facility, your DNR is no longer good. EMS may honor that during the first transport upon the next facility. So the next one is a DNR, which is a durable, do not resuscitate. And also post is what we go even further where you can really break down what your wish is. This is what you need if you're going someplace else other than the hospital. It travels with you. It goes to the skilled nursing facility. It goes to your home. So it's so important to have this because it honors your wishes when you're in your home. It is, once again, a written order. It becomes effective when signed by the provider and patient. If the patient, or if the patient lacks capacity, the authorized decision maker. The order is portable and is valid anytime, any place. And as of 7/2017, Virginia now honors out-of-state DNRs. And they don't expire. The only time they can be changed is by the person who signed the forms. You have the right to change your DNR and DDNR at any time, as long as you are competent. And that leaves us for questions.
Okay. I'm not muted, right?
There's lots of them.
Oh, good.
Yes, there sure are. And by the way, I've been tracking those of you who have indicated you'd like the presentation. I can't pull everybody's, emails from Zoom, unfortunately, but I think I've got all of you right now. And anybody else, just note it on the chat and I'll make sure I send it to you. If you don't receive it within an hour after this meeting, then I didn't catch your, that you wanted it. And yes, lots and lots of questions. I'm going to go down the list, and Kevin is here to keep me honest. So we have lots of good mornings and hellos. The first one from D. Karras asked if I could post the contact information, so you'll see that in the chat for anybody who wishes to have Anita's contact information.
Yes.
Okay. First one came from Dave and Linda Van Aken. Do you use VATS for loaner durable medical equipment?
So, no. We
Okay.
normally do not. Now, that's not to say that we couldn't. We would have to work with a company, and obviously it's all individualized, and we would have to find a company that would. I never say that anything's not impossible, because I've seen a lot of things that we thought we couldn't do. Sometimes it will take a little bit longer to get the discharge plan, but it's not a standard.
Okay, very good. And the next one came from me. When you're talking about, care management after discharge, how far out does that go, and how do you know when you're done?
So it's a little bit different if you have a Bonds Accord provider versus a non-Bonds Accord provider. So we have what used to be nurse navigators will follow you 30 days after discharge, because that's the readmission time. Now, if they feel that you need to be followed more than 30 days, they'll put you in a case management file and they'll follow you a little bit longer. But the average is 30 days.
Okay, very good. Next is Eric mentioned some Medicare Advantage plans are now covering home care, non-medical.
Correct, they are. And to answer also, one slide I added in here about the 3-night stay, some Medicare Advantage insurances do not require that, but I just put a standard statement across that so we know which ones do and do not.
Very good. Next is Dave and Linda asked, if you are married, do you have to sell your home for the spend down if only one of you is in long-term care? And our own Eve Flippen answered a little bit lower down the line. But let me pose the question to you, Anita.
Yeah, so that is a very touchy situation. So it does affect the spouse when you have to do the spin down when you're married, unfortunately. And that's the problem where we have a lot of people who are not willing to do the spin down where there is a spouse involved, because that spouse needs the money also. So we really have to have the conversation individualized, what we can do for the family. Can you move to another home? Can the other spouse go to an apartment? Can we sell the home? Can you pay for funeral arrangements for both of them? So there is a lot involved for that spin down if there is a spouse involved, because it does affect both of them.
All right, very good. And I'm going to go down to read Eve's response and then hopefully get back to the right spot again. Eve says, if a spouse or dependent under 18 lives in the home, you should not be required to sell the home. Medicaid long-term care does get tricky when people own multiple homes or make income from their home. Mm-hmm. So it's hard to make a blanket statement, but for most people, there should not be a problem as long as the spouse is still living in the home. So I think that dovetails with what.
And it does really play a role who's living in that home. And we have third-party company that we work with the Medicaid. And so they really come in and explain all the options of what we can do for the spin down and versus the rest of the family. So it's all individualized who is living in the home and what's needed.
Okay, very good. Mike Mason said Medicare Advantage plans usually don't require the 3-day hospital admission rule, and some of the plans cover some long-term care services. So I think that was, adding more information to what you were saying,
Well,
Anita.
very, very, very few plans cover long-term services. More of them do not than any do. But you are right, the Medicare Advantage plans do not require a 3-night stay.
Okay, very good. And then we have requests for presentations, and I will again try to get as many of those as, try to get all of you. Down to Debbie, who indicated Chesterfield Triad File of Life kits for first responders are extremely helpful, and a list of much of the information needed if you are rushed to the hospital or ER. And there's contact number. It's called Debbie, actually, if you want more information on the File of Life.
And I agree with that statement. It's good to put a sticker or a magnet at your front door so the ambulance will know you have a File of Life, and that's what I recommend. Keep it on your refrigerator so they know to grab it. And if you have a family member taking it, make sure they grab it.
Excellent. Ann Anderson asks, is there any way to have an advanced medical directive on your phone so EMS or the ER can access it if you are unable to?
So honestly, I have not seen any of that technology out there yet. Not to say it would go that way, but as of right now, I do not know of any programs that have advanced medical directives on the phone. But I can't 100% say that it's not out there. I'm just not aware of any.
Mm-hmm.
Great idea, though.
Yes, I'm sure there are things, out there.
Hey,
From
Julie,
Kelly Hickok, go ahead.
couldn't you scan your advanced medical directives and then save them on your phone? Would that work?
You can, but the problem is you're going to need it in your medical record. So it would be hard to pull it off your phone to the medical record. So that's the only thing. It's good to have a copy of it.
So ease of access to that information might be an issue.
It would help that we know your wishes and we could actually put it on file, but unless there is a real copy, it just really helps. If you have a family member making your decisions, it's a little bit easier. It gets sticky when you didn't want a family member to make your decisions.
Great. Kelly Hickok says or asks, if you have a plan on file with one hospital, but end up going to another hospital due to diversion by rescue personnel, can Bon Secours access it from another hospital?
So good question. That's not a standard process to ask for it. It's better to have it with you, but we could do that. Care management could get it if you say, I have it over at Chippenham and we really, really needed it. We could call Chippenham. It gets a little sticky with the HIPAA violations because if you're not able to sign a release, they're not going to give it to us automatically. So every now and then you could get someone to do it, but it can get really hard because of the HIPAA regulations.
Okay, very good. D. Karras says it's important to distinguish if the patient has been admitted or is under observation.
Absolutely. It completely has a different payer source, and that's something that we know every patient, whether you're observation or admitted, there's different regulations and paperwork that we have to discuss with you. So you will know if you're inpatient or observation just because we come in and let you know and have different CMS forms that we have to sign for each individual one of those.
Excellent. The next, Tracy Mead says, I am a Goodwill ambassador for honoring choices and a long-term care consultation. And we all know about honoring choices because that was our presentation in our April presentation regarding advanced medical directives and, getting those filled out and such.
Right.
Then we have Eve's answer. Kitty Gale asks, where does a grandchild fit in the hierarchy of?
So it's going to go, if you have a spouse, And if your spouse is not alive, it's going to go to your children. And also, if your children's not alive, it'll go to your parents, and then probably by then your parents are already deceased. And then after that, it will go to a grandchild.
Okay, very good. Then we have requests for the presentation, and then Debbie says, we can send out this PowerPoint to council members. Also, the presentation is
Absolutely,
recorded.
yeah. You can share that.
Sure. So, Joan and Debbie, should I just send it out to everybody?
So I'm going to go ahead and make a drastic change in our process of how we do things, especially now since we're doing Zoom calls, that starting with this particular presentation, could we get Linda to send the presentation out to all of the members? So that would sort of minimize that picking and choosing and someone forgetting to, it would minimize our resource time in answering those requests. Let's make it a normal practice from this day forward if we have presentations.
Okay, I still need to go through though and make sure that anyone who's not a member who is.
Absolutely.
So I'll still.
Absolutely. She can add them to the list.
And I don't mind if you send out the presentations and you develop more questions. Joan, feel free to send me those questions and I'll be glad to answer anybody.
Absolutely. So with that being said, I'm going to put my email in here. So, and that was one of my process questions, was if somebody has questions after this and or someone who's left the hospital that maybe just didn't have a clear understanding, what structure do we have in place to provide them the best education? Is that through the nurse navigator or?
So if there are bonds of court, it's going to be a nurse navigator. Unfortunately, you get into an area if they are not a bond of court provider that you follow. So they don't have nurse navigator following. So it would be up to the individual providers that you're seeing to provide that education. It's also on your AVS, which is your after visit summary of who to call if you have any questions. And of course, you can always call the hospital back, the floor, and just, if you really were unsure, get some guidance.
Thanks for that upgrade.
You're welcome.
Okay, so I'm scrolling down through all the folks who made requests. Then to Joan's question, do you direct people to elder care lawyers to help with balancing financial needs for spouses?
So we don't have elder care lawyers that we work with. We can give them a list. So if they have questions, we recommend that. We really try not to get into the practice of picking and choosing lawyers for them. We want them to do that on their own, but we will give them some phone numbers if needed, if they are unsure of which way to go.
Okay. Tracy Mead says there is a nationwide database for advanced medical directives.
There sure is.
Tracy, would you mind posting that link in the chat?
I believe Kevin already posted that link in the chat.
I was going to say,
good.
Kevin has posted it. I didn't have it handy, but I just wanted people to know that they can file.
I do see it. Yep, I just got down there and saw that. That's great. Thank you. And Debbie Preston asks, can you share best practices and changes that were made to care management during COVID-19?
Ah, good point.
That's a great question.
That's a great question.
Yeah, there certainly was a lot of changes. It definitely made the care management role very challenging during the COVID because, and it still is challenging because we did have skilled nursing facilities which changed the rules and regulations every day versus what's going on in their facility. So we had to keep on top of which nursing homes was accepting COVID patients, which ones aren't. How many, some facilities require 2 tests before they come, some require 1, and that is rapidly changing every day. So it's constantly keeping up with that. At the beginning, we had a lot of home health companies that did not take COVID positive patients. So as they got their PPEs, they let us know. And so we were able to work with home care companies and also personal care companies, working with them because many of them didn't have the proper PPE at first. And then as they got the PPE, they let us know, and so we were able to work with that. So it still is a challenge if you're positive where you can go, but there are a lot of more facilities that are willing to take the COVID. And then of course, home health and DME, we had some companies that were willing for oxygen. Some said no, that we just weren't going to deliver oxygen to COVID positive patients. So it was really finding those companies that was willing to go into these homes. Some of them do drop-offs on the doorstep, do it outside versus going in the home. But it was a lot of work, and I'm very proud of what our team did during the time, because we didn't have a huge long length of stay because of COVID. A little bit, but not horrible. Great question.
Yeah, very good. And next question comes from Linda Yarbrough. What is the most efficient way to determine what Medicare and Advantage plans will or won't cover during a medical crisis?
So it's actually, we have to do a lot of calling. It changes so frequently what they do and do not cover. Same as skilled nursing facilities. Some will take some insurances, and then within the next year, they're not taking that insurance company. So a lot was trial and error, and a lot they're able to tell us right off the bat. If we go to send a referral, they tell us that we don't take it. So you quickly learn which one takes things and which one doesn't. Unfortunately, it's not straightforward because, as we know, healthcare is constantly changing every day, and so is the insurance companies.
Okay, thank you. From Roland Winston, seems like if you have the documents saved, you could email it to the ER. I'm thinking it's the advanced medical directive that he's talking about, since that is probably a technical option. And is there another issue of not having a copy signature rather than a hard signature? So I guess, can you take?
Correct. We do not have
copy?
to take the originals. We can take copies as long as it has a date. So that date and signature is the most important thing, because it tells us when you're most current, because we'll have people give us copies, but it's the copy before what we actually have scanned in the chart. So we'll let them know you didn't bring us the most current one. If we have one in the chart, we'll just review it and say, is everything still the same? And if it is, we go by what it is on there. I do have concerns just emailing it to the emergency room because there's not a set email, and there's not a care manager who is in the emergency room 24/7. It would be okay when the care manager is actually there to get it, but knowing who's there that day might be difficulty. So it's not a practice I would recommend.
Okay, very good. And then we have the link to the advanced directive database, which is awesome. Dorothy Winningham sent to me quietly, but for everybody, do you have a patient family advisory council?
We do.
And if so, what role could this be? Yeah, if so, what role could this be an asset?
I'm sorry, you broke up and I didn't hear that whole question.
I think it's just to talk about patient family advisory council.
Okay, so we do have one. So they give the hospital a little advice, a lot of advice based on their experiences of what they've had in the hospital. We rarely get concerns for the discharge planning but that's not to say that they would never give us advice. We don't rely on the advisory council for the discharge planning. We rely on each individual patient and their wishes versus the council telling us. Now, we definitely would take any recommendations that they say because they are the ones that have been here and experienced it. And so it's good to hear patient experiences on the councils. So we can always make some changes. I mean, changes is always good in my eyes.
Doesn't the council, Anita, more or less handle what I'm going to call specific patient needs that they feel are not being answered? So they've got a point of contact within the hospital to address it. And that point of contact will either A, provide education to the patient and or get the right administrative entity involved in a solution or modifying practices.
So that's our patient advocate
Okay.
that does that. So we actually have a patient advisory council, and these are actually patients that have been here in the hospital and wanted to give some advice. And so anytime we have recommendations of changes, we like to hear their experiences and what their thoughts are. So it's not a typical case management thing that we had. We just follow more guidelines and individual care versus anything. But I would love to hear if anyone had a, question or an idea. I definitely would hear it.
Thanks for clarifying the difference between those two entities, because the majority of the people don't understand the differences.
Absolutely. So I always recommend to everybody when you go to the hospital, please remember there is a patient advocate there. So if you feel you're not getting the right care, or you have a concern regarding a nurse or a treatment or a doctor or even care management, patient advocate is the one to go to no matter what hospital you're in. They will guide you and bring all the right resources in. And that can go after you're discharged also. You can call them at any time.
Okay, let's see. Next from Mary Catherine. Dispatch Health can see COVID positive patients as well as test for COVID if the patient has symptoms or not. I have to sign off. Oh, but so she has the number for Dispatch Health there if you're interested in more information. Next, a question from Debbie Preston. Did you notice an uptick in psychoactive medication, anxiety, depression meds for folks who were hospitalized during COVID-19 and had a lack of visitors and family to help them during their recovery, especially older adults with mild cognitive impairments who might not understand why their loved one is not there, might exhibit agitation?
Yes, that is a really good question. So we didn't see an increase in meds. At first, for COVID negative patients, we were allowing one person to come in, and then eventually we had to change that when COVID got really bad. So we are back to allowing for patients that have dementia or really altered mental status to have one person, not physically stay in the hospital, but come in as much as possible. Occasionally, we would have to add more medications on. What we did see, not actually in the hospital, but coming into the hospital due to COVID, is a younger group probably in their 30s with having a lot of withdrawals from alcohol, because a lot of people were actually dealing with the COVID by drinking. So we did have a lot of alcoholic withdrawal patients being admitted for seizures and of different things, which was really sad to see.
Okay, next, Roland Winston posted a link to a story relating to the reason why hospitals wouldn't want to make legal referrals. And then Lisa Motzhead says, with many that we serve having hearing loss, here's a link that might be helpful to share for those to include in their hospital kit. Okay, that's Our local RVA Hearing Loss Association chapter will soon have kits available as well, and I'll be glad to update when they're actually ready.
Yes.
And I believe we're at the end of the chat. Kevin, have I missed anybody or anything?
Are there any other questions that maybe someone didn't have the ability to submit a chat, and maybe they're participating via cell phone that they want to ask? All right, that's perfect. I hear some.
Yes, Joan, I was wondering if you have a second, if I could make a quick statement.
Of course, Eve.
So I just wanted to say that this will actually be my last Council on Aging meeting as a member of Senior Connections as a care coordinator. I am moving on to VCU Health. I will still be working in aging services. I'll be doing caregiver support and doing some fall prevention for the seniors at the hospital there. And it has been a pleasure working with you all as an aging disability services intern, as a care coordinator in the community. I have never lived in Chesterfield, and I always find myself working there because there's amazing aging services providers. There's amazing mentorship. There's amazing opportunities here. You all have been more than amazing and more than wonderful to me, and I hope to stay in contact with as many people as possible and shoehorn myself into as many things as VC will let me shoehorn myself into. So yeah, I just wanted to say a quick thank you to everyone. That has been an amazing couple years coming into the Council on Aging.
Eve, thank you so much for sharing that. Is it okay for you to put whatever contact information you want to on the chat so we can all stay connected? And that's only if you want. Are highly respected for your journey within the council, in which you have truly brought to Chesterfield. We are so blessed. I would love to have 100 Eves at my fingertips. So
I
congratulations.
never want to see 100 Eves in my life, Joan, but thank you so much. I'm happy to plug. I don't have my VCU contact info. I can plug my personal email into the chat real quick if anyone wants to keep in contact that way. Let me put it
Only if you want.
Yeah,
Only
that's
if you
absolutely
want.
fine. Yeah.
Okay, that'll be great. Wow, you know what? Sometimes people's journey takes them away from you, but it doesn't mean that they will totally forget you. I know that, Eve, because you stay connected very well, and they're blessed to have you. I'm going to do, I've got to be aware of everybody's time. I'm going to assume that there are no more questions for Anita. Anita, thank you so very much. Your time is precious, and you have really there's a lot of professionals in this group, along with a lot of volunteers and people in the community, that in a very short period of time, you have refreshed or provided education to help people clearly understand your process. And we are thankful for that.
Thank you for having me. I appreciate it.
With